If you want clarity instead of guessing, a coronary calcium scan, CAC, is one of the few tests that can re-rank your risk in minutes. It's not a supplement, it's not a vibe, it's a picture. And that's why it's so powerful. Traditional risk calculators estimate probability. CAC can show whether plaque is already present, even when you look fine on paper. Today I'll walk you through exactly what CAC measures, who it's for, what the scores mean from 0 to high, and what to do next. No fear, no biohacker flexing, just precision. Because the goal is not to collect tests like Pokemon cards. The goal is to make one good decision with the least amount of guessing. Let's start simple. CAC is a non-contrast CT scan that measures calcified plaque in your coronary arteries. It gives you an Agatston score, which is basically a calcified plaque burden number. More calcium usually means more plaque burden, and more plaque burden usually means higher future risk. But here's the nuance that keeps this video honest. CAC measures calcified plaque, not all plaque. It can miss soft, non-calcified plaque. So CAC is a disease burden test, not a "how blocked are you today" test, and not a guarantee of zero risk. Now why does CAC feel like seeing the future? Because it changes the conversation immediately. Instead of debating your cholesterol like it's a philosophy class, you're looking at evidence of whether atherosclerosis is already on the board. This is why CAC shows up in guidelines as a risk reclassification tool. Not for everyone, not as mass screening, mostly for people stuck in the gray zone. So who benefits most from CAC? Think asymptomatic adults in prevention mode whose risk is not obviously low and not obviously high. This is the person who hears, maybe statin, maybe not, and wants a more personalized answer. It's especially relevant if you have risk enhancers like family history of premature heart disease, elevated ApoB, elevated LP, metabolic risk, or mixed lab signals. Or you're doing everything right, but something still doesn't add up. The classic use case is this. Adults in midlife with LDL that isn't sky high, no diabetes, and no prior heart event, but enough risk that you can't shrug it off. CAC can move you from "I think" to "I know" fast. A newer 2026 dyslipidemia update tightened the "who" into a very practical frame. Selective CAC use for men 40+ and women 45+ in borderline or intermediate risk ranges when the result would change the statin decision. That's the key phrase, when the result changes the decision. Now, when is CAC not the right play? This is a must-hit beat. CAC is a prevention test, not an emergency room test. If you have chest pain, severe shortness of breath, fainting, or concerning symptoms, you need proper medical evaluation, not a DIY calcium scan. And if you already have known high-risk conditions or established coronary disease, a CAC score usually won't change the need for aggressive prevention. In other words, if the decision is already obvious, CAC adds less value. The scan is most valuable when you're undecided and the data can break the tie. Now let's decode the score in a way that actually changes behavior. We're going to do this in ranges, because that's how people make decisions. First, CAC equals 0. This means no detectable calcified plaque. This is one of the strongest downward risk markers we have for short-term risk. It often allows people in the gray zone to defer statins and stay lifestyle first, depending on their full risk picture. But here's the caveat that prevents false comfort. 0 does not mean 0 plaque, and it does not mean 0 risk. It means no measurable calcified plaque on this scan. You can still have soft plaque, and in younger adults especially, 0 calcium can underestimate lifetime risk. Also, there are exceptions where CAC equals 0 should not be treated like a free pass. If someone has diabetes, LDL-C very high, is a smoker, has a strong premature family history, or has very high LP, 0 doesn't automatically mean do nothing. So the best longevity compass framing is, CAC equals 0 can buy you time, but it does not buy you complacency. It's a window to double down on the boring fundamentals before plaque shows up. Next, CAC 1 to 99. This is usually mild calcified plaque burden, but it still means atherosclerosis is present. This is where the conversation shifts from risk factors to disease exists. And for many people, that changes motivation more than any lecture about LDL ever could. In practical prevention frameworks, CAC in this range often pushes toward at least moderate intensity lipid lowering, especially as age rises. You don't need to panic here, but you do need to treat it as real. Next, CAC 100 to 299, or above the 75th percentile for age and sex. This is the zone where the scan stops being interesting and starts being a clear treatment signal. This is typically where clinicians say, okay, we are not guessing anymore. The plan usually intensifies, ApoB and LDL targets become more aggressive, and lifestyle becomes non-negotiable. Now, CAC 300 and above. This is the dramatic threshold for the video because it behaves like a different league of risk. Expert staging proposals describe CAC 300 plus as risk that can resemble someone who has already had a heart event, and they suggest LDL-C targets in the very aggressive range. The 2026 update also escalates therapy as calcium burden rises, which supports the "this is not a small signal" interpretation. And CAC 1000 plus. That's extreme burden. If your score is that high, the question is not, should I do something? The question is, how fast can we reduce risk intelligently? Now let's build the high-CAC action ladder. This is the part that makes the scan useful instead of scary. Because the scan is not the therapy is what you do next. Step 1. Treat the result as evidence of existing disease burden, not theoretical risk. This is where you stop saying, I'm trying to be healthier, and start saying, I'm reducing a known burden of atherosclerosis. Step 2. Make ApoB and LDL lowering central. ApoB is your modifiable atherogenic particle burden. CAC tells you the scoreboard of cumulative exposure. A practical framework many clinicians use is, any CAC supports tighter LDL control, and higher CAC supports lower targets. Expert staging proposals often talk in tiers like LDL under 100 with any CAC, under 70 with moderate CAC, and very aggressive targets when CAC is very high. Step 3. Statins are the foundation, and non-statins are add-ons when needed. This is not ideology, it's outcomes data and guideline-level prevention logic. If you can't get ApoB, LDL low enough with one lever, clinicians may layer therapy. That can include options like ezetimibe, bempedoic acid, or PCSK9 therapies depending on the person and the risk level. Step 4. Lifestyle does not become optional because the scan is high. CAC is best thought of as a scoreboard of cumulative exposure, not as a substitute for food quality, body composition, blood pressure control, exercise, sleep, smoking cessation, and diabetes control. If anything, lifestyle matters more because now you're treating real disease burden. The scan doesn't remove responsibility. It removes denial. Step 5. Aspirin is not automatic. Some frameworks consider aspirin when CAC is high, but primary prevention aspirin can create net harm in higher bleeding risk, especially as people get older. So if aspirin enters the chat, it's a clinician decision, not a YouTube decision. This channel is powerful, but it does not get prescription privileges. Now let's bust the repeat scan myth. A lot of people treat CAC like a yearly scoreboard, like a social media streak. That's not the evidence-based use case. If CAC is 0, some guidance suggests considering a repeat scan in roughly 3 to 7 years depending on the person's risk profile. Shorter intervals may make sense in higher risk situations, but it's not a yearly ritual. And if you already have clearly elevated calcium, the better move is usually to act on the result, not keep rescanning frequently to watch a number drift. The goal is risk reduction, not calcium watching as a hobby. Now, the downside section, because credibility matters. CAC is low-dose CT, but it is still radiation. Many scans land around about 1 to 2 millisieverts, which is in the ballpark of months of natural background radiation. For many people, that risk is reasonable when the scan can change a major prevention decision. There's also the incidental finding problem. Sometimes a scan sees something unrelated that triggers more testing, anxiety, and follow-up. And the biggest honesty line, we do not have randomized trials proving that doing CAC scans reduces heart attacks by itself. CAC improves risk classification and sharpens treatment decisions, but the scan is not a magic shield. So here's the longevity compass conclusion. CAC is not for everyone, and it's not a flex. CAC is for people in the gray zone who want clarity that changes a plan. 0 can buy you time, but not complacency. High score is not bad luck. It's information. And information is power. If you use it to tighten ApoB, tighten lifestyle, and stop guessing. If this helped, hit like and subscribe so you don't miss the next Heart Risk Masterclass. Check the description for tools and affiliate links that match today's topic, plus our Longevity Compass Amazon KDP book. And comment your situation. Are you in the gray zone, the family history zone, or the "my labs look okay but I don't trust the story" zone? We'll keep it calm, practical, and evidence first.